Dear colleagues, adequate knowledge of surgical anatomy forms the basis of good surgery. And of course, hands-on experience is equally important. So it is with these two objects in mind that we have been conducting endoscopic sinus surgery workshops at the KEM Hospital in conjunction with the PD Hinduja National Hospital for the past 12 years. In August 2003, that is this year, we had the good fortune of having Professor Heinz Stammberger of Graz, Austria, who, as you know, is the foremost exponent of endoscopic sinus surgery, a pioneer in this field, as a teacher at our workshop. We present to you the cadaver dissection that he performed for the benefit of the participants of this workshop, and we sincerely hope that this dissection helps you understand the surgical anatomy of this region much better and helps you in gaining confidence in becoming a better endoscopic sinus surgeon.
I will rather show briefly the way that we would perform a diagnostic endoscopy. Then I will go for a demonstration of the surgical steps. But please keep in mind that what you will be seeing is not a routine thing that you should do in each and every patient. This is only meant to demonstrate what can be done should need for this arise. Please, with all these steps, keep in mind that the more of those you can avoid, the better. The principle of that is avoidance of unnecessary surgery. So let's assume that we need to... Okay, let me wait for a second because... In my department, someone would be there with a knife in the back, you know, university setup, but here I don't hope that this is what's happening. Okay, we examine patients who have nasal and sinus symptoms in a lying position of the patient, of course, so not in the sitting position, because that takes one dimension of space away in which the patient might move, and patients usually are much more stable, I'm not saying happier, when they just lying flat on the back. And the routine would be that we would spray the nose first with a mixture of a mild vasoconstrictor and a topical anesthetic, wait for a few minutes, in that time, for instance, finish our standard ENT examination, and after that go to the nose. And when we go to the nose, we ask the patient to lie down. We, the investigators, sit, if we are right-handed surgeons, on the right side of the patient, like I do here, with our knees under the shoulders of the patient, and we feel one should sit because then you can be much more precise and less traumatic with your maneuvers and procedures. We use a 30-degree telescope, and I will tell you in a second why. I'm still one of these old-fashioned guys who loves to not do things off the monitor for a couple of reasons. One, which is bias, and that bias is that when I have my eye on the endoscope and move with it, I get a better perception of depth of the space. But that may be my personal bias. I've learned it that way. The other situation is, and I'm really enhanced in this belief, that what you see on the monitor is not the patient. That's a virtual image. You depend on the resolution of your camera, you depend on the colors the monitors give you, the resolution the monitors give you, and this is a very, very different thing from reality at times. So, my personal bias, if you have a chance, look through the endoscope rather than on the monitor, and you'll be surprised what it could be that you will be picking up. Okay, a 30-degree telescope, for those of you not familiar, the angle of degree always indicates how much your angle of view is away from the shaft axis of the instrument. So what you see on the monitor is not straightforward, but it's 30 degrees off the horizontal. Okay, I have my eye on the scope, and with this I insert the endoscope into the nose. I don't do it the other way around, like first putting the scope in and then waiting on the monitor for a picture to appear. By then, you have for sure already created the first trauma to that patient's nasal mucosa. There is neither for diagnosis nor for the surgical procedure any need to trim the patient's hair, with one significant exception, and that's when you can charge for that. Otherwise, there is absolutely no need to do this. The first glimpse that you get should serve general overview. Get an idea of what you're confronted with. You see the inferior turbinate, you see a small septal crest with a spur, and if you would resect that and are in the United States, you would have $1,500 extra. So that sounds like a good indication. But in this case, there is direct contact here, and I think possibly that's a real indication. Very fast, very simple. You see the gross anatomy, you see the middle turbinate, you can look up to the olfactory fossa, see whether there is any major obstacle or disease. See the middle turbinate, beautifully see the unsynaptic process outline. You cannot see the ethmoidal bulla yet, and that's the first impression. Then we have three standardized passes. The first one goes somewhere, somehow, back to the choana, because we would like to see what's on there. So we go with a 30-degree telescope, find the area that is widest, which is usually over the floor of the nose. Not so simple here because of that septal spur. Let's try anyway. And doing this on a cadaveric specimen is a very good exercise for reality, because you should not touch and not pick up debris. Then you have arrived at the eustachian tube very clearly, and now you will see the advantage of the 30-degree telescope. You can see to the left the vomer, posterior end of the septum that is, and you can look directly onto the eustachian tube opening, and if I rotate the telescope now 90 degrees laterally, I can look into the eustachian tube. I would ask that patient to briefly swallow. This would open. You can study the mechanism and even look as far as the isthmus of the eustachian tube. If I go a little further, I can even look into Rosenmüller's recess, so behind the tubal lip on the medial aspect. And if I now rotate my lens back, pointing superiorly, I can look at the floor or the rostrum of the sphenoid, where once the adenoids had been. All this rotational movement goes without any notice to the patient because it's rotated around the longitudinal axis. If I rotate the telescope now to the left, you see the vomer comes into the picture much better, and if I advance for a few millimeters, I can look into the eustachian tube of the patient's right side, see the tubal lip, see Rosenmüller's recess, and I can see where adenoids or anything else might be. I can even go on with my rotation now, 180 degrees around down, and I can look onto the soft palate, sometimes see the uvula. And if I would ask the patient to phonate now, it is not rare that with a 30-degree telescope, one can see the larynx. But this is not our standard way to look for the larynx, of course. But it shows you why use a 30-degree telescope, because with this simple movement, you can overlook even the other side, and should there be an anatomical or pathological obstacle that would prevent you from going to the patient's right side, this is what you can do here. So this is the first pass of diagnosis, and I'm going back. Can I have the cottle or free or whatever? Again, I need a dry piece, of course, here to wipe off that thing, if possible. Thank you very much. I dip it into anti-fog solution. And what else could we see? Well, had that patient been operated before and a window been created through the inferior meatus, you could inspect the maxillary sinus through that window. Here, of course, there is no one. So let's assume that your ophthalmological colleagues have asked you could you please help to identify the opening of the nasolacrimal, because there are some problems in that patient. So you might be forced to put some additional anesthetic here, but let's use the flexibility. Don't out-fracture it, even in non-private patients and enter the middle nasal meatus. It is always safer to identify the posterior end, which you can clearly see at 6 o'clock. Imagine or remember that you're looking up, and now I investigate from the back to the front. To the right, of course, there is the medial wall of the maxillary sinus. To the left, medially that is the inner side of that middle turbinate. Looking for the opening of the nasolacrimal can be tricky. Not necessarily do you need to see it clearly, as in this case. There we are. You can look almost all the way up, which is rare in reality. But you see one thing, this is more at the transition from the dome to the lateral wall rather than at the dome itself. There can be a mucosal fold, a true Hasner's valve over it. There can be a slit. It may not be visible at all. There can be more openings than one. Should you not see this as nicely as here, you would take your index finger, palpate for the inner medial canthus for the lacrimal sac, give this a gentle massage, and this would, if not squeeze out a tear, at least give you some bulging there, helping you to identify this situation. Okay, this was the first pass, choana inferior meatus. The second pass goes back to the choana again. Let this time me try to stay above that septal spur, not touching the middle turbinate, and you see that here I arrive at the superior aspect of the choana now very clearly, and this therefore is the posterior end of the middle turbinate, and I now swing my endoscope medially between the middle turbinate and the septum. You still see the choana, and I gradually work my way up without any pressure or trauma into the sphenoethmoidal recess, where you can beautifully see an ostium into the sphenoid sinus, and you nicely see the bulge of the superior turbinate. In a patient with pathology in the region, of course, you will not see the situation as clearly, but it helps to know where drainage comes from. So this is rather unremarkable up here. Now, this is the most important third part of our diagnostic approach, and this goes to the most important middle meatus. Anatomy again, middle turbinate. This here is the Aganasi region. There, of course, you have the uncinate with what some call the maxillary line. That's not an anatomical description, but it's meant to describe where the uncinate process attaches laterally here. Use the flexibility and test it first of that turbinate, and this here is very limited. You should not, especially not for a diagnostic approach, fracture that turbinate. This is considered crude, unwise, and it may be the first step of a later lateralization. Try at all to avoid lesions to the middle turbinate if you can. So if you can't enter from anteriorly, go posteriorly. Identify the posterior end here. This is where the middle meatus usually is wider, and you should investigate from the back to the front. So what you see now, what appears to be right ahead, is up, of course, 30 degrees, and this is the horizontal portion of that basal lamella. And if I would turn laterally now, oh yes, there we have one. This is a beautiful, what? Not. This was almost synchronous, great. This is an accessory ostium, and you see one thing, accessory ostia always are strictly in the vertical, whereas the natural ostium of the maxillary sinus, I hope I can show that to you during the dissection, usually have an angulation of anything of 15, sometimes even 25 degrees off the vertical. So, posterior fontanelle with an accessory ostium. I'm retracting the scope, and now this should start to show the bulla. There it is. On the right, that small crescent is the uncinate process, and I just slipped out of the meatus. So up here we have the bulla, not overly impressive here, and you can see that other gap which goes medial to the bulla. Possibly there is a supra and or retrobulla recess. So let me get out of this, and there we are again. Can I have the cottle back again? Now, if I would like to investigate further up, this is something you cannot usually do, especially if there is disease. If you would like to look for frontal recess, I'm a bit more aggressive, this patient cannot complain anymore, and this is not fracturing, this is still the elasticity. Now it's much better to be seen, the bulla here, the uncinate process, the instrument tip now disappears between the uncinate and the bulla, and if I look up, I see a couple of niches and indentations and recesses. It is usually difficult, if not impossible, to, from just this endoscopic approach, get any idea what is what. Whatever. You are looking into the frontal recess, and during the dissection, I will try to point out the different items visible here. Let me now just go to double check whether the navigational system is accurate. I have the straight suction navigator here, and something I can optically clearly identify is the attachment of that middle turbinate closely underneath the aganasi, and you see this is fairly precise. I'm anterior to the middle turbinate, and that is fairly precise. Let's go for something else, and that is the free posterior margin of the uncinate process. And you see that tiny little knob on the aspirator. This is where the computer calculates the crosshairs to. So I should be in the hiatus semilunaris between the bulla and the uncinate process, and I think that is fairly precise, as especially on the axial scan you can see. Behind the bulla I should be close to the basal lamella, and if again you look for the sagittal scan now, this is exactly where we are. Let me now test the z-axis and posterior end of middle turbinate, where you should be close to the sphenopalatine foramen, and you see on the axial scan that I'm about 2 millimeters ahead, so this is fairly precise, and now I can feel that indentation, and I'm right there. With this, I know I can trust the system should need for this arise. The RMS reading that the system gives you, better than 1 millimeter, is not the accuracy that you have achieved. It is the theoretical accuracy of the system, but only if you do this visual double control, you can trust the system and use it. 0 degree, please. Okay, 0. And there should be the flat handle with it, the flat handpiece, thank you. Okay, let's now assume that this patient requires surgery, and let's assume that this is a case where we have massive disease, so that we need to go for all of the sinuses. I will just need to decide which side to enter. Let me briefly take navigation again. One thing that you see here is, look at the flexibility of that nostril. This is what you should take advantage of. There is, one of the beauties of endoscopic surgery is you don't need a speculum. Not only don't you have to trim the hair, exception you have heard, but you don't need a self-retaining speculum or anything else. Use the elasticity, but of course don't use it medially, because there you have the columella and the septum, which are fairly painful. One of the nice things that I personally like with the navigational systems is that you can scroll through anatomy. So I can see here, and yes, this is the wider side of the sphenoid, and in this case I hope that I can expose some anatomical features better on this than on the other side. So let's start with the surgery here, the sickle scalpel. We would, prior to surgery, I told you we do everything under general anesthesia, we would have lined all the mucosa here with cottonoids, which we have soaked in adrenaline, and this adrenaline is a high concentration, 1 in 1,000. 3 zeros only, 1 in 1,000, but this is not for injection, this is just for topical vasoconstriction. We would leave that for 10 minutes or so, remove them, and then use one single injection, half a milliliter of 1%, 2% lidocaine with epinephrine, but this epinephrine now is 1 in 200,000, so quite a different concentration. And we would inject this right up here at the aganasi region, making sure that we see this part of the middle turbinate and this part of the uncinate blanch. We would wait for a minute or so. No, nothing, just mucus, and then start with the surgical procedure. With this, we have a couple of assumptions. We assume and we pretend that this patient has considerable disease in this region. So our first step usually would be the resection of the uncinate process. Nothing new, by the way. It has been described 100 years ago. So infundibulotomy is nothing new. It's nothing specific for endoscopic surgery. But this would open the way into the anterior ethmoid. There are, I believe, 120 different techniques how you can do that. Each and every surgeon loves, so do I, add his or her personal vitamin C and sell this as a new technique. Basically, whichever technique you manage to get rid of the uncinate without causing trauma is perfect. I will show you just a couple of those. If you cannot identify as clearly this maxillary line, you should always be able to identify the posterior margin. See how you can ident the uncinate process here, even without navigation, and most of us don't have the navigation. So use this, and it is much safer to go through here and resect the uncinate in a stripe-wise fashion than to fumble around here looking for the right place like I'm doing now. This would create bleeding, and this little maneuver could have turned what might have been a very nice, fascinating surgery into a mess for you and the surgeon. Why? Because the bleeding that you've created here will trickle along your instruments, your endoscope, etc. So one situation is that you go through here, but in this case, it angles away very nicely, so I dare to go as far lateral as this. You see that I have the tip of the instrument pointing laterally now, and I palpate, difficult to describe, going through 3 layers now. Mucosa, bone, mucosa again. And before I start to incise, one thing is mandatory. Now turn the scalpel absolutely parallel to the lateral nasal wall to avoid that you further continue to go laterally and possibly into the orbit. So through, that's 2 millimeters, no more, rotate parallel, and then you incise either upside down, as I do here, or the other way around. Retract your sickle outside of the middle meatus, rotate it, go in again, find the same area, and then you incise, and you see that I'm aiming towards the insertion of that middle turbinate, but I don't cut into there. What have we reached now? You see 3 layers, mucosa, bone, very thin bone, mucosa again, and we look straight onto the bulla. You don't believe it? Let's take the navigation. And there we are, on the anterior face of the bulla. Now, how to resect the uncinate. There is a lot of diversity. Standard Blakesley, please. And that is, you must use through cuts because standard instruments don't go. You need a shaver. You can use everything. But remember, it is not the instrument, it's your hand, and again, the mind behind the hand. And I will therefore like to demonstrate the oldest instrument, 120 years, a standard Blakesley, of course refined by Storz, but you can do it. It is not the instrument. The only thing you can do wrong is grasp here, and that's true for any instrument, and pull. That's what you should not do. You should resect it down here and up there, and you should do so without trauma to the surrounding areas. Yes, you can take scissors if you have them. Storz and everybody else would love to sell this to you, but you don't need it initially. You can do it with a shaver and publish it. Great, but you don't need it. The thing is that you need to understand you would like this to come off as neatly as possible. So if you grasp it, don't do one thing, that is on the left side of a patient, rotate things like this, because this can tear the mucosa, see this, into the inferior turbinate. It may sound minimal, but this helps to avoid troubles. It helps to avoid wound area, to remove mucosa where it's not required. So, on the left side on the patient, inferiorly of the uncinate, grasp it as close to the attachment, and think of our Australian friends with a short alligator-like rotational movement, just twist it, and your uncinate is precisely off where you want it, even with a 120-year-old old-fashioned instrument. Now, go up here superiorly, and there already the little things are important. that instrument has one moving branch. So you should not put it or squeeze it in here, requiring room for the non-movable branch, with which you might injure that portion, but think, rotate, grasp up here, and now, of course, the opposite is true. You should not rotate or strip in this direction, because the mucosa might tear over to the middle turbinate, would create a raw surface there, and that could be the pre-stage to scars and adhesion. So you grasp it, make sure you grasp it all the way, close to the insertion, think of Australia, alligator, and there you go. It comes off, and here you have the uncinate process. Okay, again, write a paper on it, use the shaver, whatever, but take it out. 0-degree telescope, looking straight forward. Can I have the ballpoint seeker, please? What have we achieved now? Well, we've done something as simple as resect the uncinate process. Of course, not all of it, but there's no need to do that, because we want to go further back. This would be an alternate technique. I go behind, I fold it out, I can even do it and just remove the bone and leave the mucosa and call this MIST, minimally invasive sinus techniques. Okay, in German the word MIST means nonsense, to put it friendly, and I would not like to comment on that. No, to be serious, the thing is there are hundreds of different possibilities as long as they serve the same goal, atraumatic removal, they are all perfect. Okay, assuming that our patient has disease now in the anterior ethmoid, straight Blakesley please, let's go on again. This clearly is the anterior face of the bulla, and the next step therefore would be to resect the bulla. Before or when you do so, before you take a really hearty bite, make sure that there is a lumen. Take your first bite medially and see how with the back side of the instrument, the blunt side, I use this to push away a little bit out of the way the middle turbinate without creating trauma, hopefully, and make sure there is a lumen. Think of the old dissection techniques on the neck region. Make sure you see a lumen, with disease or without disease, because not necessarily must this be a cell. If this is bulging, it just could be the orbit. And once you're there, you can take it again in all kinds of ways. And let me still stick to the alligator movement. Once you open the bulla and start to resect it, don't go for a partial resection, but rather go for a complete one to avoid that any remains stay back there, especially medially, where they might be in contact with the middle turbinate. Okay, so where is it that we are at now? Bulla is, is gone by and large. If that is right, with this here, we should look onto the anterior wall of the basal lamella. So this is the horizontal portion of the basal lamella, which you can beautifully see being followed now. I hope that shows on the large screen. And this is the edge around here that I've described. You can always identify this, and if only by palpation. Now, I told you some 3 to 4 millimeters above that, which I think is here. You go back, and that's your way posteriorly now. This is a fairly complex situation of the ethmoid with very many cells, but this is, as I hope you clearly can see, the way through. Standard Blakesley again. I would like to point out that you can do with very little instruments to begin with. So, same technique, if you go through, make sure that there is a lumen, and there is one, and you can go on. Now let's go for a variation, the circular cutting. Small, straight punch, the mushroom punch. Again, this is only one possibility, one of many. This basically has been designed for sphenoid work or others. The beauty of it is it has a blunt head, and when you insert it, you can, without having to rotate the handle, you can cut to the right, you can cut down, as you see here, you can cut up, you can cut to the left, you can cut to the right, etc. Nurses hate this instrument. It's difficult to clean, but I have to admit, I love it. Standard Blakesley. The important thing is that we don't take away too much of this basal lamella, as this helps to stabilize our middle turbinate. So let's gently, now that we see better, go further posteriorly into, where are we? Posterior ethmoid, of course. Still working with a 0-degree telescope, which allows straightforward view only. Can I have that circular cutting instrument large now, straightforward? What I'm doing now is what you should avoid in a real patient, but I'm trying now to strip the mucosa to give you a better display of the underlying anatomy. So this is still part of the bulla. We even have some of the uncinate. Let's go higher superiorly. And if I have in mind to go for the sphenoid because of disease, this is usually what I would do first. Not do anterior ethmoid work to minimize the bleeding I would get there for a variety of reasons. The main reason definitely being that I would not like the blood to go up there. You might see that I do not look much for the navigation in routine case, but in this case it's so beautiful to have it that we can point out things. Horizontal portion of the basal lamella, and we have a space back here which is at the orbit. So one information is, don't go laterally now. Even if you think you can, and I'm sure you could, but you shouldn't do it. But the way towards sphenoid proper, and there are other cells of the posterior ethmoid, should rather be in this direction. So Blakesley again. All this only needs to be done if there is disease. There is no routine step in that. So we are further back, and I have the small circular, well, I can do it with that, no problem. Okay, so we've arrived, what I would consider is the anterior wall, or closed, maybe one cell layer in between, of the sphenoid, and you see there is one more cell behind this, and I'm in a bit cruder fashion go through that, the small circular cutting straight, please. And that should help us, I think it's okay, to arrive at the anterior sphenoidal wall. Same technique, going up there. And again, what I'm doing now, don't do in a real patient because that parietal mucosa should stay behind, but here it serves nicely to display the anatomy. Okay, behind that. That's a beautiful one, something you very rarely see, and you would not have seen had I left the mucosa behind. I'd hoped for it, but I wasn't prepared for it. This, of course, is the posterior ethmoidal artery, a very rare glimpse. The circular cutting large, please. Maybe another comment, for all kind of surgery, whatever it is, whether that's tumor, CSF leak, angiofibroma, what have you, there are two people at the table. It's the nurse and the surgeon. So there is, everybody can see what's going on, of course, on the monitors, but there is no need for any assistant to irrigate, etc. Okay, where are we? Let's briefly, Blakesley, go back. You see the middle turbinate. It's still in very good shape. It has not been traumatized. Let me just remove that debris here. There's a piece of uncinate still. Horizontal portion is there, and the turbinate as such is very stable. We've resected the bulla. This was the second incision line through the basal lamella. We've not approached skull base. That would be up there. There you can see it. Now, for the first time, we are at skull base, and that's in posterior ethmoid. That's very tough. This here is posterior ethmoidal artery, and there we should be at the apex of the orbit, and behind this we should be able to enter sphenoid. Navigation is dangerous because now you can control what I told you. Okay, posterior ethmoidal artery. Could well be. Let's go above that. I should be at skull base. I think that needs no further explanation. Behind the artery, very close to the orbital apex. I think that's a very nice one. And there I'm on the orbital apex even. And maybe I can demonstrate another thing. You see, this is incredibly precise now. However, this is a mechanical and computerized thing only. If you, the surgeon, behave wrong and don't realize, like I'm demonstrating now, of course the system goes wrong. And I'm now using this navigation device as an instrument. I start to lean on it, and with this it bends a little bit. Endoscopically, you can clearly see that I am not in there. Do they get oh yes, you have it up there, okay. But you see that I'm about 5 millimeters inside orbit, but I'm not. However, it is my fault, not the one of the system, because I was leaning on that, and even very good steel, amagnetic steel, will flex a little bit if you put enough pressure on it. Yes. With this, the tip moves, and the tip is where the crosshairs are calculated. So you should keep that in mind. It's usually not the system that is wrong, but we who don't understand how to work that. This, of course, is the favorable one of two options. You see, the system says, whoops, you're in the orbit, but I'm clearly not. The other way around would be more difficult and problematic. If the system tells you you're way from optic nerve, but in reality, you're 2 millimeters in. Those possibilities exist. But again, it's not the system, and that applies to any system. We need to know how to handle these. Okay, I've talked enough. If you see the posterior ethmoidal artery, that's small, correct, standard, straight, small. Okay, then we need to open sphenoid sinus. Or it's about time to do so. I had a dry gauze somewhere there. I think I moved it over. It's okay. Just to wipe things off. Still straight? Okay. So, and I told you, if via this approach we go into the sphenoid is located much more medially and inferiorly than one would assume. So I would therefore just sit here and turn my instrument towards 8 o'clock on a patient's left side and towards 4 or 5 o'clock on a patient's right side, going down. The worst thing to do is to go on in this direction, as a little later I will demonstrate that this already is very close to the optic nerve tubercle. So let's see if I'm right without navigation here. Going through, very thick bone, but now you see I've broken in, pressed a bit too hard, but even if that were reality, my instrument was pointing medially and downward where there is little chance that I would cause any trouble. The circular cutting mushroom. Okay, now I've created a small opening, possibly still too small for the mushroom forceps, but no, it succeeds. So now let's see where we are. And here again, we can cut to the left, to the right, going up a little bit, and getting a better view into the region. This blunt head of that instrument almost 100% prohibits that you, or prevents that you could grasp anything which is other but frontal located. And you know very nicely, once you see the posterior ethmoidal artery, you have some 3 or 4 millimeters down to the sphenoid. What has happened? Have you realized? I am somewhere, but that somewhere apparently is a small cell above, because I do not, that's a small or noddy cell, because sphenoid proper should be located further inferiorly. It was the current again, not very well visible on the scan, maybe due to the windowing, so let's go further down. But you see, we avoided problems, but that's a very interesting one. Okay, I told you don't go on here, and most likely there we will have optic nerve already, but now we are safe here and just go down. Okay, no, this is sphenoid sinus, and that's very nice because that is something that happens during real surgery every now and then. When I broke through the bone, I pushed in front of me the mucosa. So that looked like another cell, but it isn't. So therefore, here you already see some nice bulging structure, which I will leave for a little later. Let me now try to demonstrate a through cut, the standard straight through cut Blakesley. This is an unusually thick bone in the region, most likely no disease, and again, rather than trying to force that in, you see it opens to the wrong side. I need another instrument. Of course, you don't need another instrument, you need to think. You turn that instrument around and suddenly everything is perfect. Okay, this now is thick bone, so there we have a through cutting instrument now, and that will help. Let's try with the large circular cutting mushroom. It is rare that you have to use a drill up there, but it may occur. Those instruments are only designed for relatively thin bony walls, but now you see that works nicely, and I can go all the way down. But again, I don't get the impression that this is always something which is as radical as I'm here. I just want to create sufficient opening to that sphenoid sinus. Now, standard Blakesley, I do one thing that, again, you should not do. I will strip the mucosa, but only for the sake of anatomical demonstration, which, by the way, is much easier in a cadaveric specimen than in living patients, luckily, because it should be avoided. Mucosa would regrow back there, but again, this would not be something which is what we would like to have. Okay, where are we? 0-degree telescope, middle turbinate. We have opened anterior ethmoid, not totally cleared. We are through posterior ethmoid. We've seen skull base. There are some segments. We've seen posterior ethmoidal artery. And we now look into a beautiful sphenoid sinus with all the good friends around. Who's who? Okay, correct, please. Let's try to find out without the navigation, like most of us will have to do. Okay, the artery, the anterior wall, the apex of the orbit, so optic nerve should be somewhere up here, and here we have a beautiful display, and you can see, let me stand on the wall of the optic nerve. It is rather thin, isn't it? So I hope that shows. This is something that we should avoid, and there the optic nerve then clearly goes on. Okay, optic nerve up here. Under the optic nerve, you see another good friend whom, like in real life, you should not get too close to. This is just mucosa here where I've stripped it. And you see this is still injected, a little reddish, and you all know this bulge, of course. And let me just test. Well, the bone is very thick over it. So this, of course, is carotid over here. And yeah, luckily, I even have problems in breaking into. But if you remember that in patients with chronic rhinosinusitis, this is a very, very thin bone, can be dehiscent totally, and this, of course, is carotid during its intercavernous sinus course. Let's try to display that with the navigator. Apex of the orbit, very clearly, and I'm indenting now a little bit into the apex and to the optic nerve, just in continuation over here. And I will try, I'm limited somehow by the cable. Can someone, okay. We can go down and we approach, and I'm next. I can't go around the corner with that straight pointer, but you see that we have approached carotid. It's now for the first time that I switch to either back the 30-degree telescope, just to get some idea how things look inside sphenoid sinus. Okay, so that's back to 30 degrees. It's not been cleaned. That shows that In our OR, we have a special jar into which we have the endoscopes stand when they are not used, with some gauze at the floor and with some sterile water to avoid that debris and dirt like blood would stick to the tip of the lens. Okay, 30 degrees, we're looking up to skull base, very nice, posterior ethmoidal, optic nerve coming out here, and I'm going in and now rotate the lens laterally where you can better see optic. You can see the carotid, and down there, well, you can look down into sphenoid sinus proper, the floor, and back there you can even see the vertical part of the carotid artery. We are pointing straight towards the clivus, nothing else which is of special interest in that case up here. Okay, let me now stay with that 30-degree telescope, and now, still under the assumption that we have massive disease up there, let's work my way from the back to the front. Very briefly give an idea of where we are so that you can fully appreciate the anatomy. Posterior ethmoidal artery, this is the angle between the apex of the orbit, exit of optic nerve, and the orbit itself. This, therefore, should be skull base, and very clearly tells me don't go a millimeter higher there where you are. And now I come from the back to the front, and I have two guidelines. I have the lamina paperatia over here, and I can even see the yellowish fat shine through. I don't know how that shows on the monitor. Another thing that I love, looking directly through the endoscope. And now for the first time I would use upturned instruments, standard Blakesley, 45 degrees. You do not have to perform a total ectomy all the time, but let's assume we have to because of disease. So always only work when you can see what you can do or what you are doing. Especially if I turn medially now, I use utmost care not to run into the lateral lamella of the cribriform plate. And here, possibly by chance, see that whitish structure next to my instrument? Could be that dura is close already. And you see how far below, see that, skull base that is. So I'm doing what I like to allude to as cosmetic surgery, just nibbling away those crests here. In any case, not leave bone naked or exposed because that will cause long-standing granulations. Okay, and now the decision is first for frontal or first for maxillary. Let's try frontal first, assuming that this patient has massive disease up there. And you see already one limitation of the 30-degree lens. I can look up. I see that this most likely is remnant of uncinate, that there is something of the bulla, which I go behind, but I can't really look behind that. And this is why we have asked Karl Storz to produce a 45-degree telescope. No, that's the lateral one, the straight one. I will use that a little later. Because those extra 15 degrees are very, very helpful up there. You see that we have that small handle which really helps to guide and stabilize the scope. Okay, so same approach but with 15 degrees of angulation now. Maybe you can see another thing, though the camera is not heavy or bulky at all, it rests on the back of my hand. It's sort of self-stabilizing there. 45 degrees. So you're looking 45 degrees off the straightforward axis, the curved curette. There's one with 65 and another 90. That's perfect. And again, very simple instruments. Nothing so much sophisticated so far. Clearly, this is peri-orbit. Look at that. Thin like ice. Okay, and it's yellowish through and through. Skull base of posterior ethmoid. And now we're working anteriorly, ethmoidal roof. Look at this strange pyramid. Could it be that that's the artery? Could well be possible, but I'll leave it alone first. Let's go up and see where we see frontal. There is a structure that is anterior bulla wall. Standard Blakesley, upturned. Let's see whether we can reach there with the Blakesley still. And you see, yes, you could use a through cut, but there is no bad need for it once you really gently manipulate those instruments. Very gently doing away with this up here. And you see another cell opens, and this lady or gentleman had a fairly complex system. Where is it that we're going up here? Let's try, can I have the curate again, the curved one? Let's try with our anatomical knowledge without any navigation. What would we do? Well, we know, let's assume this is the artery, and it looks pretty much like, okay? Horizontal part of the roof of the ethmoid, there something swings up and it appears to reach a bit over the orbit. This either would be an unusually far posteriorly opening frontal, most likely it is a supraorbital air cell or recess, whatever you would like to call that. Well, how do we know? If that's the artery, many times one would think, oh great, that's the frontal sinus already, but usually it is not. Well, you have the artery, and the next pit looked from inferiorly then always leads into a supraorbital recess, and it is the next pit anteriorly, so somewhere here, that would lead to frontal sinus. Is that total nonsense that I'm telling you? Let's take the curved navigator now and see if that is true. Ich Schweiß? Nee, es sei denn, es ist auf dem Film nicht schön. Okay, that should be skull base. Okay, and now I go into this thing which I told you could be a supraorbital, and bingo. Yeah. This is not the frontal. Especially on the sagittal, you can nicely see that we are behind this. Could you go to magnification, one higher, 4:1? I think I need to go out, is that correct? Okay. Okay, let's do the same thing again. 45 degrees, looking up, and I'm now going in with the curved navigator. You're familiar now, middle turbinate, again, skull base, anterior ethmoidal artery, I believe, and now I go into that space, and now on the sagittal you can much better see the separating bony wall. I try to approach it. I can't quite yet now touch it, and you see anterior to that, this is frontal. So many a time we would have believed, oh, isn't that nice, we have the frontal, nothing I need to do, but this is not the case. So what else can we do? The curate again. Let's assume we don't have the navigation, which I think is pretty standard. Okay, insertion of the turbinate, there was uncinate going up here, so this here is a blind. I can feel that. This must therefore be the terminal recess, a small one. Okay, so if there's a terminal recess, I must go medially to the terminal recess. That's what we've just learned, because then the frontal drains medial to that. And if that is supraorbital, let's see what it is that happens here. Let's go up there. Very gently. Is there anything that will help? Oh, I see something up there. Can I have the giraffe forceps opening AP, anterior, posteriorly? Yes. That's sideways, and there should be one which opens anteriorly, posteriorly. Okay, so give me the sideways one. Maybe I've forgotten to put them out. Again, a very simple instrument, a small one going up, and I try to see, I know this is all nice in theory, and I'll try to look up where we are. This is not the frontal, don't get me wrong. And get up there. Yes, thank you. There's no need that you whisper. That's okay, now you can see supraorbital recess. We have that separating wall, and I will start to take this separating wall away with, again, another unsophisticated, simple little instrument. The critical thing, however, is here the mucosa. That should not be totally torn away. Could you please clean that? And I'm going up now. But this mucosa I can remove because that was just a layer of the bone here, which needs to go anyway. So this will not be the mucosa covering the lateral walls. And now we go up here, and we have still not arrived at frontal. That is quite a tricky situation. Can I have the 90-degree Kuhn curette? 90, thank you. If now someone says, hey, why don't you take a drill, the septum, go up there, that's all very nice. But this is not where the good Lord has created the drainage pathway of this frontal sinus. So, supraorbital, we've touched here. So this is then the anterior segment of the cell. And this is fairly tricky now. Palpation, going up there. Okay, I'm through that cell, and I am here. And that opens another space, and that could well be our friend, the frontal. If you look at my position, you will see I will never operate like this fool that breaks my back. That's true, and therefore I will switch to another 45-degree telescope. Can you put it on? Which has a lateral light entrance. Okay. And that gives me extra room to work. You see now 45 degrees, we're still looking up, but the light comes from this side, so all the room underneath here is completely free. Now let me take the navigator to demonstrate that we are really there. Okay, so the same 45 view, but I have a much better way of acting. Supraorbital recess. This is the wall we had just penetrated, and if I go in here with my navigator, that should be now inside frontal itself. Bingo, and there we are. So this is the true frontal sinus. So had this patient had significant disease, then this would be a very tricky one. And we will now go for a wider communication between those two compartments. Again, supraorbital, and up there is the frontal. And I will now try to reach around the corner, and I can't with this angulation. Again, the 90-degree curette. Very tricky case. Sometimes you're glad that some patients die before you see them as a sinus case. I know that was not very fair, but this is, those really are the tricky cases, you know. And imagine she would be someone who had taken an aspirin and tell you, no, I've not taken one, and it would bleed more, then you would, the giraffe forceps, any will do, then you would be quite in trouble. But I think this additional effort is quite worth going for it, because now we are getting closer. Okay. To do this without a 45-degree telescope and these simple but correctly angled instruments would have been very, very difficult. Let me go and give you a ride now up there, and there you see that we are in frontal sinus proper. I will again try with the mushroom forceps to get up there. But for this, I guess the problem is not the forceps, it's that spur back there where I can't really bring that up. But now we can, or can't I? No, it's just that thing. Now, I will not, giraffe lateral, I will not rest until that's open, lateral one. Basically, I'm confronted with the situation that we all are in our everyday procedure. I have done enough, I'm sure, up there, but I can't resist to do more. And I think this is where problems start for our patients. We don't need the widest as possible. No, you never can get there. The giraffe again. So now I lost the track of what I wanted to say. Sorry. No, it was something else. Maybe it will reoccur to me. The worst thing up here would be to really strip all of the mucosa. Try to get that small piece of bone again. Yeah, I think we now fairly have succeeded up there. Can I have the 90 degree again? It's better than it appears because I've pulled down some mucosa. Good. Okay. So there is the back of that one intrafrontally reaching air cell, and if now I have smoothened everything, this is frontal sinus proper. And if we go up there, we have a nice communication up there. That's about what you can get. Everything else is very narrow bone. So especially here, any additional trauma one would create, I think, would increase the potential for stenosis up there. Let me go back to 0 degree very briefly. How are we doing time-wise? I can't see any clock here, any watch. How are we doing? Anyone has a watch? How are we doing time-wise? Okay, 0 degree, and I would now like to, the standard current, identify the maxillary sinus ostium. And you can see that despite all this hassle up there, the middle turbinate is stable, it is in situ, the horizontal lamella is there, it is not fractured, it's just around. Okay, where's the maxillary sinus ostium? We've seen accessory ostium here, even with the 0 degree I can see it. Now it helps that you remember what you had done. This is, of course, the resection line of the uncinate. This, of course, is the resection line of the bulla. So, consequence, the hiatus semilunaris should be somewhere here, leading into the infundibulum, and the natural ostium must be hidden behind this final remnant here. And I've on purpose taken the 0 degree lens, backbiter please, opening to the right. If you see, without resecting the uncinate, a hole, there is a good chance that this is not the maxillary sinus. You see, with that backbiter, don't you ever insert it like this and bite back. With this, you will definitely go into the nasolacrimal. From behind, only hook behind uncinate process and resect this. And there you see a couple of interesting things now. Let me just smoothen this down very gently. Okay, there's the horizontal one. And now we go back to our lateral view. Let's say 45 degrees, the standard one, or 30, whatever comes first. Standard 45. Thank you. Still no information on the time.
10 to 15 minutes.
Okay, good. Okay, I rotate the lens laterally so that I point towards the ostium. Kuhn's curate, the curved one. Go underneath the turbinate, and now you can beautifully see the difference between the 0 degree lens. I've not, D65 please. I've not changed anything with the exception of the endoscope. There is the accessory ostium, almost in the vertical, exactly. And there now, behind those uncinate remnants, you can see the position of the natural ostium, which is tilted some 20 to 25 degrees off the vertical. That's a good help to differentiate those two. To demonstrate what you would use if you reach into, or have to reach into the maxillary, it's this instrument designed by some Mr. Heuwieser, who is in office practice somewhere in Germany, and you see that opens nicely, and you can go down and reach almost each and every corner of that sinus should you need it. Let me briefly, and I was told there are some 5-10 minutes or so straightforward, show a few 0 degrees straightforward, thank you. A few other features, Cottle again please. And that is, if you go and try to identify the posterior, for posterior epistaxis, the sphenopalatine, for sphenopalatine artery. Okay, we all know, just shifting away that debris a little bit here to clean up, but you see we have performed a total sphenoethmoidectomy. In that case, we've identified the optic nerve, we identified carotid artery, skull base, posterior ethmoidal, anterior ethmoidal, supraorbital recess, frontal sinus, turbinate is still stable. Wherever you look, there is mucosa, with the exception of where I on purpose have removed it. A frequent thing is that you're confronted with identifying or ligating branches of the posterior ethmoidal artery, and we have found since many years one of the safest ways to go there is as follows. We all know that the sphenopalatine foramen is somewhere near that posterior end of the middle turbinate, which we clearly see here. But it can be at the level of turbinate's end. It can be 5 millimeters down, 5 millimeters up. It can be 5 millimeters anterior to that, down or up, or 5 millimeter posterior up. So you're talking about an area of a square centimeter where you would not like to spend much time to fumble around creating additional bleeding there. So you identify the posterior end. About a centimeter or so anteriorly, you go to the lateral wall and make an incision onto the bone. It's very important that you go through mucosa and periosteum. Sometimes you break into the sinus, especially if you have an accessory ostium like in this case, but you see that I'm developing now the plane between the bone and the periosteum. And in doing so, I gradually go further posteriorly, okay, elevate this, and can I have a freer now, please? Okay, and not knowing exactly where the artery is, I now load the entire posterior end of that middle turbinate onto my freer, and I pull that middle turbinate towards medially, gently. The older your patient, the more gentle you should be, because the vessels can be fragile. And with doing so, the middle turbinate's end pulls out the branches of the artery of the sphenopalatine foramen. If you're not too rude, like you beautifully can see now here, it's a series of branches, inferior one, and there the cotyle again, and there the main stem of the artery. And now you can do whatever you think appropriate. You can cauterize it with a bipolar suction cautery. You could clip it, and there you have them, okay? That's very clear. This is the spine they usually tell you you should find. Should I stop? Are we out of time? I don't get that. What's that?
That's an approach of appreciation for the way you did it.
Yeah, but that's decades old. That's a standard thing. There's nothing special.
Love the way you
Oh, sorry. I really thought you wanted me to stop. No. Sorry for that. I really was a bit flabbergasted now. Okay, this is usually the spine that they tell you in papers you should look for. But if you have a posterior bleed or you do tumor surgery, you don't have the time to do that. And we find this technique rather helpful. Do we have on display one of these bipolar suction forceps? So I could just show the black one, you know, that thing. And whether you now clip it, cauterize, that's totally regardless. But again, the key is move that turbinate gently medially, and with that posterior end, automatically the vessels will be pulled out. And there you have them. And once you did it, here, this is, for instance, the instrument that we would use. It is a bipolar, as you can see, suction cautery. And you would bring it back there, and now you can cauterize this, grasp this, etc., or you put a clip on it. Let me use the navigator now to tell you where we are. This is that tiny spine, and this would be the sphenopalatine foramen. And I think you can see that we are fairly precise going up here, right in the middle of that canal. And if you would like to find the Vidian, etc., all you would have to do is drill this, in this case at least, because it's so thick, and you go up there. But let's assume we had just to deal with the vessels. So we have cauterized or clipped them, and all we would do now is fold that mucosal periosteal flap back, put a sponge in, Maricel or whoever you have a contract with, whatever, and leave it alone. And that usually does it. To show how reliable that is, let me just briefly try to do that on the other side. Oh no, that's not wasting the time. Let's show one more thing I wanted to show to you. One is, look at the orbit. This really, why it has the name of lamina papyracea, the paper-thin lamella. This is, by the way, exactly what one would be doing for orbital decompression, as you will see a little later in patients with endocrine orbitopathy. So you gently fold this away, and in a real patient, say with an intraorbital bleed, all you would do now is incise this and allow the orbital fat to protrude. And if you go further posteriorly, this will take you exactly, let me briefly try to do that, to the cleavage plane, to the optic nerve. You should do so without any damage to the periorbit. Don't get too close to the posterior ethmoidal artery. And you see this is where the tubercle is and the optic nerve originated. Now the bone is getting sort of too thick. Most likely I'd ruin the instrument. Yeah, okay, but I think you see what I mean. This is optic nerve where it swings up and medially. And see the whitish stuff? These, of course, are the fibers of the annulus of Zinn, the narrowest fibrous portion up there. And yeah, maybe we can have a sickle just to incise that if that's okay. And to briefly demonstrate how we would do an emergency decompression now. All we would do, go in here, but 1 or 2 millimeters only, go through the periorbit, you see, and that would really take away the threatening pressure, because you see now if I put a little pressure on, and that usually would be enough, at least as an emergency procedure, to take away any threat from optic nerve, etc. Okay, again, total sphenoethmoidectomy. What else can I, oh yeah, the curate once again, standard curate. Last thing possibly to show, the standard one, thank you. I told you that if we are in the vicinity of the anterior ethmoidal artery, up here, we're always afraid of going through skull base superiorly, but that's rather thick bone. But the artery, you can see it shine through a little bit over here. Where this goes medially, it goes anteriorly, and it thins the bone there. And let me see if it's true in this case or species as well. No, that's a very thick bone, luckily, but normally this would exactly be, it has to come like this, of course. Okay, this is well protected, but so I simply ask you to believe me that normally this is the area of danger where we would break through most easily, and it's very reassuring to see that there are people, or have been people around, where this would not work. Okay, anyway, but this is the region which... Anything that I could do in a few moments, as long as we're on that specimen? DCR. That's such a boring and fast thing, but okay. Yes. Well, pituitary, I'm afraid, with that thickness of bone. With that thickness of bone, let me start with that first. I will not have a good chance to go to the pituitary. Well, you would go down with the mucosa, identify here the level of you can see the optic nerve, so you would be behind there, the level up here. This would not be a patient suited terribly well for pituitary surgery. So you would have to drill up this here. I'm very rude now, but I don't have really the drill to go. What I want to do is create a hole big enough for the navigator. Here we are at the dura, the straight navigator, to tell you I will not be able to expose things further. I'll need a little force even with that. So, well, you see that we are arriving in the pituitary fossa, and yes, well, so, and, but this bone is too thick to allow for a nice and easy and rapid navigation, but yes, there we would. I'm afraid that's all I can do in this situation. The nasolacrimal DCR, can I have the Cottle again? I would not, let's use the same site because possibly that cadaveric specimen will be used again. What we would do is we would not touch at all the ethmoid. We would create a flap, let's say a little anteriorly. I'm very rude now. And I would push that flap back. Tell you in a minute why so. It is based superiorly and it will be based inferiorly. And I would just push that back. With this, it would protect to some degree the entrance into the middle meatus, which I would not normally operate on. And now, this bulge here is where the nasolacrimal is behind. I hope I can demonstrate this situation with you. Normally, I would not resect the uncinate, but on the posterior medial aspect, this is where the bone over the nasolacrimal usually is thinnest. So let's see if that is correct. There is our way into the ostium. This is the bone. And if you now look to the axial scan, you can nicely see that we are where we would like to go. You can see the opening. Can I have the standard curette again? I will need that in the end, yes. We don't even have those instruments up there, the Hayek or Kerrison, the thick ones. Okay, that would be the way now up here. And even with the 0-degree telescope, you can see now the wall being exposed up here. Don't believe it? Okay, navigator again. Gently fumbling this away. Okay, there you see we've exposed the posterior wall now. Can I have the ballpoint seeker, the Lusk seeker? Okay, so now that I see this here, see that's the structure, I need to go up first, go up here, go up there, and then I would drill away the bone from here if it needs to be, and you see how thin it is. I was given the Kerrison punch by my very charming assistant here, but of course I have the ego to do it without that, because the bone usually is very thin, and if you proceed like this, this will keep you from creating damage or injury from anteriorly. Okay, all this I've been doing with the 0-degree telescope. Can I have 30 now? And we are done in a minute. Ja, das müssen die mir sagen, kein Problem. Ja. Okay. 30 degrees, which I will rotate a bit laterally, and let me use, I think the navigators, so many may think this is a total overkill, and I would agree, but if you have it, it is nice to have it there, because you hook behind that bone and look for the axial, it really tells you there you are. And this is the end of you considering, could I be too high? What if I incise here? Could it be the orbit? No, if you do it there, that is perfectly okay. And once you find that, can I have the sickle please? Then you are perfectly right. Okay, now with we normally would have a sickle which has a bayonet type angulation. Okay, here comes the, see that thin bone up here? It's always the same, and this is the area too where you have least arteriovenous plexus around. And now I would go up here. Can I have the ballpoint seeker again? Opened it. Okay, into the lumen, and you can look up now into the nasolacrimal, and that would get us as high as the fornix of the nasolacrimal. That's the lumen. Of course, I could probe it from outside, and what I think is most, or what we have learned, upbiting Blakesley, what I've learned is most important is that you don't waste your time a lot with any upturned Blakesley, any will do. With how to incise it crosswise, longitudinally, whatever. The most important thing is that you resect significant portions, I would say 5 times 7 millimeters, of the medial wall of the sac, because that will prevent it from re-stenosing. Let me try one thing, the 65-degree Kuhn. We had an unusually wide inferior opening. Okay, welcome to the show. So we are right. This was not just a gimmick that I told you. And I would resect more, and in the end, I would fold back the mucosa. Can I have the through cut Blakesley now, the straight one? We do not use stenting apart from exceptions. Now, what I would do with this, the mucosa from here, I would create a defect here as well. So this is just creating defects. I resect mucosa, any straight curate. And now I would fold back the mucosa, which would cover the bone here. But there is no mucosa to cover the area of where I've just opened the sac up here. That, of course, would go in a real case just for cosmesis, but basically that's it. We only would stent if there was an additional stenosis in the canalicula themselves. But if it's in the duct and you can open it like that, create a defect. So resect 5 times 7 millimeters of the medial wall. Then there is little chance that that would restenose again. Anything else? For what? No, I didn't. Sorry, no, I didn't get it. It's too. Vidian. I will do it all the afternoon if any one of you can give me one indication for which this is justified. But basically, if you believe, and I think this is more philosophical than a surgical problem, if you believe in videoneurectomy, the name alone, ectomy, you tear it out, any cottle or anything like that. You have to proceed pretty much like I did for the artery. So let's find our level again. You have the plane, there's the artery, and like in, say, angiofibromas or whatever takes you to the pterygopalatine fossa and or the infratemporal fossa even, you would have to drill. And this here is very massive bone. You would have to clip the artery, and we would, of course, resect further. Can have a straight through bite. You would have to resect further the medial wall of the through bite, through cut, yeah. Thank you. Through bite, through cut was right. So in this case, I would like to see the anterior wall of the pterygoid, which is here. So you see that, and you would have to drill that away until you arrive in the sphenopalatine fossa. Rarely only can you look into the sphenoid sinus when you see that there might be the video nerve exposed at the floor, which you see much better on the scan, but there is nothing here, and you could go into there. But basically, that would be the approach. What else apart from sphenoid? We still have one side. Say again, please. A lateral canthotomy. Okay. A 0-degree telescope, the sickle scalpel, and I need a cameraman. Well, you see how difficult it is with those eyes having sunken back. Okay, this should be how you should hold the camera. Can you try? Okay, let's put, and best if you control it on the monitor. Don't get too much of this. Okay, you rotated it. It's not that simple. Okay, like that. Perfect. Give me the sickle, and give me a freer. What you would do, let's assume this is the eye that it had bled into. You would anesthetize the eye if you still have time for that. You would go under the lateral canthus to protect the globe, okay, like this. Then you would take a standard scalpel and not that sickle, and you would go through here. It's difficult to do it with the sickle. Can I have do we have any scissors? Any ordinary scissors?
I'll give you the scalpel.
Or have a scalpel? No, with this, those delicate instruments don't go through there.
Okay, you can use this scissor.
Okay. Okay, this is sort of a makeshift thing now. Okay, now Cottle. You see I'm protecting the eyeball. Cottle. There we are. I have it. Okay. This is bone here now. And the next thing you would have to incise is through here. See, that's the conjunctiva. I'm protecting this again. Full thickness. And now you have the orbital septum. You should come a bit closer with the scope so that people really can get. Okay, now, and try to angle it like this. That's what they, exactly, that's what they would like to see. And you try to stabilize. Oops. Perfect. Okay, I'm through to the bone. This was where the canthal ligament was fixated. Now you go through, protecting this all the way. No, that's okay. Stay close, so that they can see. But in the, perfect. And back there now, you have the orbital fat. You can see the slightly yellowish appearance under the fria already. Let me try to push on the eye now, and you can see that there's the fat protruding. And that's what you need to do. It doesn't show that well on this cadaveric specimen because the individual layers are not that clearly presented. But the most important thing is full thickness incision until you're, there, trying to get that, until you're on the bone, and then go, and that's a little bit lateral and behind of the eyeball through the septum, the final fibers of which you see here, until you really identify the orbital, the fat here, which protrudes out there. Try to put that in the center of your picture. No, the fat. Right, get into there. Yeah. There you. Okay. Okay, that's. And some say that you don't even have to suture this small incision. Anything else? Can someone coordinate this? It's difficult to understand here. Where's the organizer? I think you should, Milind. Modified Lothrop. For this we would need the drill. Mr. Lothrop never ever in his life worked endonasally, this only for curiosity. And Modified Lothrop is the American version for the draft procedures. We do not perform these routinely, and I will comment on that in a short while in my lecture. That's it. Okay, thank you very much. We'll need a few minutes to change.